Broadcasting from New York City to the world, it's the G-Man Interviews.
My name is Teresa. I was an addict that was totally out of control, and I needed help.
Drugs have literally taken me nowhere. 4 incarcerations, totaling like close to 20 years in prison. We learn. This place more or less got me on the right track.
You try to do it for mom, you try to do it for your children, you try to do it for your mate. But the only way that it works is when you do it for yourself.
I became active with drugs around 1989. Through all of that, I became HIV positive.
I don't think I would want anybody else to have the type of life that I had. It wasn't good at all.
One day I just woke up and I was tired of, doing what I was doing, so I wanted to seek some treatment.
Addiction Research and Treatment Corporation was the base of their beginning as well as start their new program. And I'm very proud of both of these entities.
It is very simple for us to dismiss individuals that suffer from addiction. It's easy for us in our society to turn our heads and our back on them.
Some people think that people just do drugs just to get high. And for some people it's true, for some people it's not. Sometimes you self-medicate when you have problems and pain, and that's what I was doing, basically.
The truth is that we all have to remember that addiction is an illness, and it is a treatable illness.
I started going to groups and conferences with my counselor and things like that, because the only ones I basically had in my life at this time, my daughter had started trusting me again.
It's a relief to be somewhere that people are concerned about you and care about you.
When a client comes into our clinic, they get treated as a whole person, and they get treated from every aspect of their lives that might be an issue.
We work with them in creating a viable career path so that they can become employed.
Basically give you tools how to live out there.
It's given me stability and independence, and fortunately I've been on a few other programs, but this one seemed to work out the best for me, and I've managed to stay clean for at least 3 or 4 years now.
We provide the mental health services to adolescents while they're involved with the New York City juvenile justice system. The average age range is from 12 to 16, but we've had as young as 8.
We had a lot of neglect, sexual abuse, as I was a child. So I started using at a young age to block all the pain.
I started with the hard stuff early, and I ended up stopped going to school because I was in high school at the time. I was basically just running the streets.
It is through START that I and my partner and I get to participate and support the most disenfranchised members of our community that might not be reached otherwise.
We experienced, like other not-for-profits, a reduction in government funding. We had to figure out how to do as much as we have done and even more with less. With all the things that we do well, individual, group counseling, primary care, HIV care, family counseling, we had to make sure that we can maintain the integrity of that by focusing upon other relationships.
I personally give to START primarily because I know where my money goes. I know that my money and my contribution makes a meaningful and direct difference in individuals' lives.
Being a corporate sponsor or just being a corporation in general, we have this responsibility to give back to our communities. To see what START was doing and the services they provide, not only do they help individuals recover from their addictions, but they also help individuals with everything else that's encompassing their life. By bettering that one individual, they can now go back into their community and be a better person in their family, be a better person at their job, be a better person overall, and see that powerful impact trickle down to those that are involved in their life and in their social circle.
START changed my life. It has enabled me to every day make a goal and continue it. I can't see a day without this program.
I saw positive people. I saw that there was people can change. START made me realize I could feel better about myself without drugs. It brought me and my family closer. There's more trust, more understanding. And I feel much better being drug-free.
Welcome. Joining me for this special episode on drug addiction in America are Dr. Lawrence Brown, Patricia Williams, and Lucy Miro-Quesada. Dr. Brown serves as Chief Executive Officer of the Brooklyn-based START Treatment and Recovery Centers, and Ms. Williams and Ms. Miro-Quesada are the directors of the organization's treatment clinics. Dr. Brown is responsible for all aspects of healthcare services, oversight of healthcare professionals, and the conduct of behavioral and biomedical research. His scientific contributions have focused on addiction and improving treatment of substance use disorders, resulting in hundreds of articles, chapters, and published abstracts reflecting research sponsored by government and private industry. Dr. Brown's experience includes past service as President and Board Chair of the American Society of Addiction Medicine, Board Chair of the U.S. Anti-Doping Agency, Board Member of the College on Problems of Drug Dependence, and Board Member of the National Black Leadership Commission on AIDS. He currently serves as a member of the Drug Testing Advisory Board of the Substance Abuse and Mental Health Services Administration within the Department of Health and Human Services. He was recently appointed by the Governor and confirmed by the New York State Senate to serve as a member of both the state's Public Health and Health Planning Council and Behavioral Health Services Advisory Council. Additional information on Dr. Brown's career has been posted below in the description area. On April 24th, I conducted a Skype interview with Dr. Brown to discuss how START is playing a key role in not only battling drug addiction, but helping to place people on the road to recovery. Thank you for joining us, Dr. Brown.
Thank you for having me.
How long has START been operating?
The agency was first founded as the Addiction Research and Treatment Corporation in 1969. It rebranded to START actually last year. And the reason for the rebranding was that we needed to have a way to begin a dialogue. And our prior name, the name by which we were started under, was number one, too long, and number two would turn off the dialogue because it started out with addiction.
Is START an acronym for something?
No, it is not, and that's another story. But as START Treatment and Recovery Centers, the purpose of using START was to, in fact, do what happens in marketing. You might say issues, for example, Nike doesn't stand for anything. Or in many cases, we no longer understand what IBM stands for, even though it was an acronym some decades ago. So we wanted to have a name that was short enough to allow a conversation to begin, and quite frankly reflects the fact that we are talking about persons who suffer from a disorder where it is important that they have an opportunity to start over.
Who was the driving force behind its development?
Its driving force were, quite frankly, a number of individuals. And they were motivated because at the time, the then Mayor Lindsay wanted to throw his hat into the national scene. And his advisors informed him that there was a substantial problem with addiction in New York City, that he needed to demonstrate how his administration was addressing the issue. So he brought together a number of outstanding academicians, persons in public service, physicians, psychiatrists, to form the Addiction Research and Treatment Corporation in 1969. At that time, it was all males. That is no longer the case on our Board of Trustees now. but these were persons who had substantial influence. And they recruited my predecessor, Dr. Benny Prim, to become the first chief executive officer in 1969. And he retired from that position in 2011.
And the three key objectives of the START Treatment and Recovery Center are?
They are reflected in our mission, and they are care, education, and research, providing the most compassionate and evidence-based clinical care, educating both stakeholders within and outside about the value of the services we provide, and continuing to answer the questions today to improve the care for tomorrow through research.
How has the facility fared overall in terms of helping patients with recovery?
Over the decades of existence, the agency has provided care to over 40,000 New Yorkers. It is very true that, like other not-for-profits, we've had challenges. For example, in the economic recession of 2008, it was difficult because, as New York State and other states, the not-for-profits caught the cold. So we had to make some major revisions, including actually recruiting someone from the outside to help us develop a strategic plan. And in that strategic plan, it became clear to us that not only did we have to continue providing the services that we did, but we had to do it smarter, and we had to be agile to respond to the challenges in the environment. It also meant that we had to be involved with dialogues such as the one I'm having with you to tell our story and not just be told by others.
As the CEO of the organization, you're charged with a number of tasks. Could you briefly list and explain a few of them?
No question, and quite certainly. And quite frankly, they are not that many because they reflect the stakeholders that we have in our agency. Number one are the patients that we serve. They represent our universe around which we rotate. So we have to make sure we provide value to them. Number two is the funders, the persons who, the agencies that provide us donations or provide us grants or provide us money through tax levy dollars to deliver the service. We have to make sure we do so responsibly. Number three is the stakeholders internally, both those, the line staff, as well as the Board of Trustees, because they are the ones who provide the overarching guidance as well as the execution of that guidance. And last but not least are the communities in which we serve. We believe that if we provide the responses effectively to the groups that I have already shared, that we will have a healthy individual who will lend to a healthy family and a healthy community.
I have a two-part question here. What's the biggest misconception that people have about START programs and drug addiction?
The biggest misconception is that these individuals who are suffering from this disorder, that they did it to themselves only, and the suffering that they experience or that of their families and loved ones are due to the volition and that they could stop easily if they chose to do so. The reality is that it is true that no one starts with smoking a cigarette or smoking marijuana or using a drug that they're forced with a gun to the head. But it is also true that once the exposure occurs, I would probably put addiction in the context and analogous to heart disease. In heart disease, the end organ of importance is the heart. So anyone who has high blood pressure and diabetes, they suffer consequences to their heart. Someone who has an addiction or a substance use disorder, the end organ here is the brain. Once you have exposure, then you in fact put into play a complex series of steps that it is not as easy to change those without assistance. Many people, don't get me wrong, many people can, but there are people who need assistance. Just like persons who have diabetes or hypertension. Many individuals probably resolve their blood pressure problems or their blood sugar problems on their own. But at some point, their disease progresses that they need assistance. What we're saying to the general public is persons with addictions have a disorder that initially began with some degree of volition. But at some point, it is no longer volition that is the major player. It is now that the brain has been affected in complex ways that will require both behavioral interventions and, in some cases, medications.
I'd like to revisit something that you said a few minutes ago. In the 5-minute video posted on the START website, people from the business community talk about the importance of supporting programs aimed at fighting drug addiction. As you mentioned earlier, back in 2008, the country was thrust into an economic downturn which not only resulted in a record number of job losses, but losses in profit for many of America's top companies and/or corporations. Moreover, across-the-board cuts to funding programs at the federal and state level have only made things worse. 2 years ago, I met with the CEO of a major New York City foundation that provides substantial grants for children's programs. He stated that the foundation could only give a fraction of what it once did 4 years ago, and that it wasn't likely to get any better anytime soon. How has START been able to maintain its programs, staff, and quality services when more and more businesses, corporations, foundations, and government agencies are scaling back on donations and funding?
We have adopted a number of different interventions that, as a group, allowed us to work smarter, not just harder. One of those is using technology more so than we had. That has allowed us to train staff to use these skills to do what they were doing previously, not only just sooner, but better. So for us, the ability to perform had to change as well in response to these external challenges. It also has meant that we had to look at the way in which we recruited staff, how we maintained them, how we assess value. So everyone had to come up with a value statement, not just longevity. While that's important, it is not as important as accountability, particularly given the fact that we're using tax levy dollars. And because of this, and because of our strategic plan of telling our own story, we believe that sharing this information with people who are willing to listen and also can share with them how it helps, for example, big business, their bottom lines, to have a healthier workforce by making sure they have access to treatment for the behavioral disorders in the same way they have access for the treatment of medical disorders. That much of what we do in society, in fact, much of what we do in healthcare, if we really investigate it and examine it closely, the major causes of excess morbidity and mortality are due to behaviors, not due to genetics, not due to environment outside of behaviors.
Prior to this interview, I was contacted by 3 substance abuse counselors on different occasions. They allege that the system is enabling addicts instead of providing the help they desperately need. After visiting their facilities, I was able to confirm their allegations. However, they declined to appear on the show because they feared retribution from the agencies they work for and their peers. Would you say their claims echo the sentiments of many in your field?
I would say that they are exceptions to the rule. Now, the reason why I say that is that clinical care is not a black and white. It's shades of gray. And we've come to appreciate that every patient deserves a chance and every patient should have their own special treatment plan. As you know, beauty is in the eye of the beholder. So one clinician can say that I believe they're enabling, while another clinician is saying, well, you know, they've shown some evidence of progress. And no, they have not quite gotten to the desirable clinical outcome, but I believe we can be a little patient for a little longer. I am certainly in agreement that clinical care is a two-way street between the clinician and the person receiving care. They both have to collaborate, and the failure can't be just ascribed to one without understanding the impact of the other. I have no doubt that these individuals who spoke to you, that's how they feel. But I have also no doubt that there probably are circumstances that may be other factors that are in play. And by the way, I do come to appreciate, even though I'm trained in medicine, in behavioral health, is often said, you can't take away someone's perception, even though you may not agree with it. It is their perception. You can't dismiss their perception, even though you may not agree with it. It is their perception. But I do believe it represents an opportunity to collaborate. And it is also true, the fear of retribution is again a perception that we can't easily dismiss. Like other not-for-profits, we have in place certain procedures, for example, whistleblower procedures. We can't take retribution against an employee for calling out something that he or she finds with some reasonable intent, reasonable positive intent to describe something that they think is not appropriate. But at the same time, I've come to appreciate, particularly when behavioral health, where you don't always have a concrete measuring tool. For example, we can take an x-ray of someone to see if they have lung disease. There are certain diseases that you can't easily take an objective measure, and you have to then use a constellation of different factors to come to the best clinical decision.
This next question is based on an op-ed that was posted on the START website, which you had written. The death of Academy Award winner Philip Seymour Hoffman shocked his colleagues, family, and millions of fans, some of which may have been battling addiction as long as Hoffman. When high-profile figures like Hoffman die of drug overdoses, does it help or hinder your effort to stop patients from using drugs?
It is quite regrettable that we as a society have to wait till someone who is high-profile acknowledges a disease before we're willing to even listen, not to mention act. So it helps in the sense of bringing attention to it that many of us already knew, but there were others in our society who were able to ignore it. That's what really hurts those of us who've been in the field for so long. But we will take the attention where we can get it, and we hope to, in fact, make the attention here analogous to being a lemon to becoming a lemonade. We are hoping that that would allow more of the public to understand that this is a serious disorder with serious consequences that, quite frankly, is around us everywhere we look. But many of us choose not to look. Instead, we have the NIMBY syndrome, when in fact it is in our front yards.
In terms of it hindering your efforts, I brought that up because when somebody like Hoffman passes away, a major celebrity, and there are patients who are battling addiction, and they're made aware of these passings, they may have even been fans of a given celebrity like a Whitney Houston, is another example, and they pass away, what hope does it give them that they'll be able to kick their habit or they'll be able to come clean?
That's a good question. And I believe, as many of our patients will tell you, that everyone has a unique journey. We can't treat everyone with the same cookie cutter. And it is also true the response by the clinicians depends on that particular patient's journey. So many of our patients have said, somehow or another, they're not surprised. But they also know that it means that they have to work on their disease. And let me be any different than the other chronic potentially relapsing disease, where there also requires effort. It's just that this is a disease that is so stigmatized that the efforts that are performed by those who are successful, they don't want to disclose because of the stigma. So they look at it from the standpoint to say, well, yes, I have work to do. And for those who are progressing in their recovery, wow, I could have been in that position had I not made decisions when I made them. Or wow, I am glad that I am in the vacuum of safety, the safety net of START. So yes, there are some patients who will view this in a way that is not constructive or productive. But it is also true, it represents an opportunity for us as clinicians to be more proactive, to speak about it, not ignore it, to recognize there are things that can cause us to relapse. We say in our field, people, places, and things. We have to realize how those three entities can assist us in our recovery or can be responsible in part for our relapse.
Complete this sentence. If I could have a one-on-one meeting with President Obama and acting U.S. Surgeon General Lushniak to discuss a recent and extremely disturbing development regarding drug addiction in America, I would tell them about...
I would tell them about the way in which our society responds to the concerns about drug addiction and how we can be even more effective without really spending a whole lot more money. I would tell them that I appreciate their leadership because, quite frankly, what they say is listened to by many people, even though they may not agree with them. And I believe that this is an effort that will require enough of us in society to look at the information that's in front of us and use that to inform policy rather than just attitudes.
Thank you for sharing your time and insight on this extremely important issue, Dr. Brown. I greatly appreciate it.
Well, I appreciate the good work that you're doing, and I'm glad that there's someone out there who has taken the stance and the approach that you have shared with me.
Thank you for that. On April 18th, I visited START's Harlem office and conducted a roundtable interview with Ms. Patricia Williams and Ms. Lucy Miro-Quesada. Ms. Williams entered Columbia University as a 9th grade dropout and not only earned her psychology degree, but was also a magna cum laude, elected to Phi Beta Kappa, and received honors in her field. She obtained her master's in social work from Hunter College School of Social Work and is currently a licensed clinical social worker and a credentialed alcoholism and substance abuse counselor. She has worked as a program director at a number of facilities and now works as clinic director for Kaleidoscope Clinic at START Treatment and Recovery Centers. She is an advocate for medication-assisted treatment and believes it is the most appropriate treatment for opioid addiction. As a counselor, Ms. Williams earned awards for clinical excellence from Mount Sinai Medical Center and the Spirit of NADAP Award from the National Association of Drug Abuse Problems. She is a frequent presenter at NASWA's Addiction Institute and is presenting this year on resilience in substance abuse women with trauma histories. Ms. Miro-Quesada earned her BA in psychology while living in Lima, Peru. She earned her master's in social work from Fordham University's School of Social Work and has attended the Institute for Modern Psychoanalysis. She has been with START since 1982 as a counselor, a mental health consultant, and is now the clinic director at Starting Point in Harlem. She has also worked at the Institute for Modern Psychoanalysis, providing individual therapy to patients, and is staunchly committed to patients in recovery. She believes that change is possible and that medication-assisted treatment is vitally important in the recovery process. Welcome to the show, ladies. As the clinic directors, what are your responsibilities?
We're responsible for the administration of the whole clinic, the behavioral science, behavioral health part, and the medical part. And our responsibility is to oversee that each component, all aspects of functioning are properly covered. So we interact with medical, we look at counseling staff, behavioral health supervisors. We make sure that the maintenance and security of the clinic is in place. And we interact with community organizations, and we do presentations outside. We try to outreach to others and get the word about the good treatment that we do.
And as Lucy said, we're pretty much responsible for everything in the program to make sure that it runs effectively. And our outreach efforts have been something that we've been working on very hard lately, because we really do want to reach the people that are coming up now that are using heroin, because a lot of them are not turning to medication-assisted treatment, which is the premier, according to NIDA, National Institute of Drug Abuse, and SAMHSA. Medication-assisted treatment is the most effective treatment for heroin addiction.
What's the most difficult aspect of your job, and how do you handle it?
Sometimes patients come to treatment as the last resource because there are too many stigmas associated with being on medication-assisted treatment. So when they come in...
I'm sorry, for example, you say there are stigmas. Could you give an example?
Sure. Nobody wants to be associated with being part of a medication-assisted program because they said, oh, you are addicted already, you are an addict, whether you are on methadone or whether you are on heroin, it's the same thing. If you are on methadone, it's very hard to come off methadone. You start getting a lot of physical symptoms. It eats up the calcium in your bones. Your teeth start getting rotten. So they have a lot of ideas that they feel they are not helpful to their image. And a lot of times also they don't want to, they prefer to do drugs without people knowing them than coming to a program and anybody seeing that they're coming out of a program because they will be seen as the methadonians, as they were called before.
Yeah, the stigma is the hardest thing that we have to work against. The myths prevail, the idea that methadone rots your teeth and harms your bones is really prevalent. The average methadone patient will tell you that, even though there's a lot of education that goes on to teach that all the studies have not shown anything like that to be true. So the stigma is one of the things we have to fight the hardest against. People don't want to be identified as methadone patients. We have patients who are successful in a number of careers, but they are not seen by the world. What the world sees is our few very dysfunctional patients. We do have them, and they're the ones that are more visible, and the people that are doing great are not seen.
If a drug user listens to or watches this episode and decides he or she wants to get help, what can they expect when they walk through the doors of the START Center? In other words, walk me through the process.
When a person comes to START, they are brought upstairs to meet with the clinic director or the behavioral health specialist, the two people in charge of the program. And they're asked why they're here, what are they, what's going on in their lives that they're considering medication-assisted treatment, and their identification, insurance, and stuff is taken from them, and they will go through an intake process, which involves a lot of questions. We have to be very clear that somebody is addicted to heroin. We wouldn't want to start somebody on treatment that's not clearly addicted. So the intake process is extensive. So they go through all the questions, and then we also do a mental health assessment on people as they come in. We want to get an idea of where they're at in terms of their mental health, because there are so many people with co-occurring disorders. And after they go through that process, they meet with the medical office, who makes the final determination about what dosage to start them on, and that's basically what they can expect.
Out of all the patients you treat, what percentage would you say are teens?
We don't tend to have teens. I've had 21-year-old, but it's very rare. There are a lot of teenagers right now using opiates. But what happens when parents, with the assistance of parents, they often end up going to detox or to drug-free treatment, to rehab. And again, I think I mentioned this before the interview, that's all well and good, but the relapse rate is tremendously high. But when someone's young, many people think, why would we put them on methadone when they're young? Give them a chance to see if they can do it with drug-free. So most people don't come to methadone in their teens. Now we're getting more and more people in their 20s who've been addicted since their teens.
If a patient is under 21, they have to have 2 years of addiction. And, addiction is determined by tolerance and withdrawal. So the tolerance increases every day, and if they don't have the drug, they go through a lot of physical symptoms and psychological symptoms. So if a patient is under 21, it has to be 2 years of addiction, of dependence. If a patient is over 21, it has to be 1 year. And as Patricia was saying, we want them to try something and see if it works for them before they come to us. And we will support them if they need to. They have been patients who have come like at 19, and they were in treatment for a long time and it didn't work for them. And at that point, we felt that it was necessary for them to be on medication-assisted treatment.
What impact, if any, will the Affordable Care Act have on your efforts to treat these patients?
The Affordable Care Act may allow for more people to be on Medicaid, and that is the main form of insurance that we take. So hopefully the medication-assisted treatment available to more people.
This interview is being conducted in your Harlem office. In the 1970s, heroin was the drug of choice and killed many people in and around the community. Recent news reports revealed heroin use has returned with a vengeance in America and has claimed the lives of thousands. On a scale of 1 to 10, as far as heroin being an extremely serious problem in the community, where does Harlem rate?
I would think that Harlem rates at around an 8. I think it's back in Harlem.
That high?
That high. I mean, I take heroin addiction very seriously, and I think that Harlem is no different from any other part of the city. That it is in every borough, but I think that the seriousness of the problem dictates that the number be an 8.
And is there any specific thing that you could point to cite why it's so high? Be it a social condition or?
I think so many things contribute to a person becoming addicted. I know that a lot of our clients come to us with trauma histories. So a lot of people, we're just coming now to understand just how prevalent child abuse and child sexual abuse is in our society. And what's happening, a lot of the heroin addicts are people who have gone through this kind of trauma, and using drugs is the only way they can cope with the symptoms they have based on the trauma.
And I think also, we are working more, we're doing more comprehensive type of treatment, trying to address the co-occurring disorders, with the substance abuse, because in the past it was separated. And I think one of the barriers is that a lot of providers really don't understand how are they connected. So when they see a patient that is coming and is on a methadone program and is coming for psychiatric treatment, they don't get the help that they need. That if it's a patient who is not in substance abuse treatment, because they don't think highly of them as somebody who doesn't have a substance abuse problem. And a lot of times you don't know what happened first, if substance abuse or mental illness. And so we should be able to help a patient go through the process and try to give them the most comprehensive care we can. And that's what we're trying to do. We refer a lot of our patients to mental health clinics. We try to coordinate the treatment with them. And we try to help them understand that this is something that they need to address, that we're here to help them, and that we will do anything and everything we can.
START is moving more and more to more integrated treatment within the facility. We do have therapists available for clients to be able to do therapy here, but sometimes for medication management they have to go outside.
And some of your patients may in fact be veterans, be they Vietnam veterans or those who have served in Iraq and Afghanistan.
Absolutely.
So you're dealing with them from a mental health standpoint, and you're dealing with them from the drug counseling standpoint.
Right.
A lot of them receive benefits at the VA hospital for PTSD. So a lot of them are already set up with the services, and those who are not, we try to refer them to different centers so that they can get the help.
Does this facility support the use of naloxone to prevent heroin overdoses?
Absolutely. Absolutely. In fact, we refer our patients to places where they can obtain naloxone, especially those that are still, when people are first in treatment on medication-assisted treatment, they often still use heroin occasionally. So if we know someone's using heroin and may be injecting, we refer them to places where they can obtain naloxone so that they can use it in case them or a peer overdoses.
There are a number of news reports on this subject, but there seems to be controversy surrounding its usage or people having access to it.
Right. There's a number of Department of Health initiatives where they're giving addicts naltrexone so that they can have it and have it available in case of overdose.
And they go to a training. Usually they go to a training and they teach them how to use them. But it really, if it's used properly, it really can save people's lives. So I think they have to use a better judgment to see if somebody comes there and it's intoxicated and all of that. They probably will not give them anything. We have patients who have taken that training and they have been able to help.
And they carry naltrexone with them in case they encounter an overdose on the street. They feel proud that they have the ability to assist.
Do you believe the legalization of marijuana in New York State would impede START's efforts to fight drug addiction?
I don't think it will impede. Personally, though, I think that opening the door for something to become legal, it's very risky. I think that a lot of people can claim that they need this for medicinal purposes when it's really not the case. We don't admit patients with the primary diagnosis of marijuana. In our case, we only admit patients with the primary addiction of opiate dependence. So the only program that admits patients with any type of drugs is REACH. And most of them are for cocaine use, benzos, alcohol, could be marijuana. But our programs, it will not affect us.
Well, the reason I raise this question is because there are those who consider marijuana to be what's known as a gateway drug.
Right. The legalization of marijuana, we have a number of patients who use marijuana. Mm-hmm. And we work on that in counseling as we address all other substances. Some of our patients abuse other drugs, and we address that with counseling sessions. The legalization will probably not affect us greatly, as Lucy said, because our primary, people come to us mostly with opiate addiction, but only with opiate addiction, but it will affect other drug treatments who are working with people who have dependence on marijuana.
I happen to know several people that are battling drug addiction, and one of them recently said something to me that was pretty profound. She said, "The programs are called treatment and recovery. I understand the treatment part, but I never understood the term recovery. My battle, just like every other addict I know, is ongoing. You never recover. You just take it one day at a time." Is she right in her assessment?
Absolutely. It's not recovered. Nobody is recovered. Recovery is an ongoing process that lasts for a lifetime.
Thank you very much for taking part in this interview. I greatly appreciate it.
Thank you.
That's going to do it for this edition of the G-Man Interviews. I'm the G-Man, and I thank you for joining me. Until next time, stay cool, stay safe, and stay informed.